First of all, we would like to thank you, Professor Roberts, for joining the interview today. And it is our great pleasure to invite you and to have you in this interview. So first of all, we would like to know more about your research first. So we know that, Professor Roberts, your research focus more on the mechanisms behind the development of the hepatobiliary, pancreatic cancer. So as we know, these kind of cancer usually being diagnosed at a relatively late stage. And so a majority of the patient or a significant proportion of the patient cannot receive curative therapy. So can you elaborate more to us about what are the reasons behind the late diagnosis of these cancers, and also what are the major risk factors of each of these types of cancer? Thank you.
Thanks very much, Professor Yip, and it's a great pleasure to be able to have this conversation with you, and an honor. And really have followed your work, and I appreciate the opportunity to have this conversation. So I think if we think about the hepatobiliary and pancreatic cancers broadly, I'll start with the liver cancers.
Sure.
In a sense, I think, have the clearest idea about what the risk factors are for primary liver cancer. And, chronic viral hepatitis worldwide is the commonest cause. And I think of the two major chronic viral hepatitis, it's hepatitis B and hepatitis C that are the major risk factors. And these, of course, are transmitted through quite different means. A lot of chronic hepatitis B is transmitted by maternal fetal transmission at the time of birth, or by horizontal transmission in the first few years of life. On the other hand, hepatitis C seems to be transmitted mostly in circumstances where we do not have, in a sense, safe practices of exposure to blood and body fluids broadly. And there's a number of circumstances, and actually, paradoxically, a number of these circumstances have to do with the healthcare environment and the dental care, the use or reuse of needles, and such exposures, including, of course, before we had tests for diagnosis of hepatitis C, there was a lot of transmission through the blood, through blood transfusion as well. In addition, we know now that alcohol and alcoholic liver disease frequently progresses to cirrhosis with scar tissue in the liver, and that's also a major factor. And increasingly in many countries, we're seeing the development of metabolic dysfunction-associated steatotic liver disease. And of course, we now associate alcohol as one of the subtypes of metabolic dysfunction-associated steatotic liver disease, but also what we call metabolic dysfunction-associated liver disease that's related to the metabolic syndrome, and so related to the presence of diabetes, hypertension, hyperlipidemia.
Right.
So I think those are some of the major risk factors for primary liver cancer or hepatocellular carcinoma. Now, it's important to remember also that there are associated factors that are environmental in many places that contribute to the development of cancer. And in many parts of the world, particularly in parts of sub-Saharan Africa, but also in parts of Asia, for example, exposure to dietary aflatoxins is a major contributing factor to the development of liver cancer. We know, for example, in the past in China, there's been exposure to aristolochic acid, which is from the Chinese wild ginger. And then we are learning more recently that in Mongolia, for example, exposure to coal, products from coal, burning coal for heating within buildings, that also appears to be a risk factor for development of liver cancer. For the biliary tract cancers, it appears as though we divide them into intrahepatic, perihilar, and distal bile duct cancers. And the intrahepatic cancers, which are from the smaller bile, develop from the smaller bile ducts, appear to share some of the risk factors with primary liver cancer. And so patients who develop cirrhosis from chronic liver disease, chronic viral hepatitis, alcohol, or steatotic liver disease are at increased risk of these cancers, of intrahepatic cholangiocarcinoma. But in addition, we have diseases of the bile ducts, chronic diseases of the bile ducts, including, for example, in parts of Asia, the liver fluke infestations, for example, that cause obstructions in the bile duct, inflammation of the bile duct, infections within the bile duct. And then in other parts of the world, we also have the immune-related liver disease, such as primary sclerosing cholangitis, that also causes inflammation in the bile ducts. And in general, it appears as though anything that also causes stone disease also, increases a person's risk of developing chronic infection and cancer in the bile ducts. There are a few congenital disorders, such as the congenital cystic diseases of the bile duct, and that are also important. I think it's interesting, but for pancreas cancer, where I think in some ways we know the least about what are the major risk factors.
True.
I think that there's fairly strong evidence that inflammatory diseases broadly, and this may include non-alcoholic steatotic liver disease, may be a risk factor. Across, of course, many cancers, we know that smoking, for example, increases risk of cancer broadly, and that appears to be true for pancreas cancer as well. But the other factor that I haven't mentioned at all, of course, is underlying host genetics, and the fact that it appears as though there are inherited genetic risks for these cancers also.
Thank you very much, Professor Roberts. So very detailed explanation on the major risk factors. So we can move on to the next questions, I guess, because Professor Roberts, you now work in the Mayo Clinics and you are the head of the hepatobiliary cancer laboratory. And we know that your focus more on the advanced methods for early detection, diagnosis, treatment for primary liver, biliary, and pancreatic cancer. So can you tell us more about the latest development of the early detection or the early diagnosis techniques for HBP cancers? So what are the latest development for treating the cancers?
Thanks. In terms of early detection, I think probably the most important advances are coming from the newer technologies that we have for understanding cancer, and the opportunity to apply these technologies then to see if we can identify what we call through what we call liquid biopsy, to identify products that are made in cancers that then spill over into the blood and are present in the bloodstream. And so there's a number of different types of analytes. A lot of biomarkers for cancer in the past have been protein-type biomarkers, such as the alpha-fetoprotein, the alpha-fetoprotein L3 isoform, the des-gamma carboxyprothrombin. And I think at one level, we are learning better how to use those biomarkers and how to combine those biomarkers to improve detection of cancer. But in addition, as we've learned how to examine the genomics of cancer, we've recognized that there are a number of different types of changes that occur in cancers. One of them particularly is hypermethylation of DNA, where the genomic DNA of the tumors becomes hypermethylated at particular locations in the tumor cells. And it is possible for a particular tumor to try to identify the specific regions that are methylated or differentially methylated regions, and potentially then to develop assays that look for those differentially methylated regions in patients to see if we can improve the sensitivity of early detection of cancer. And there are a number of efforts and a number of assays that are being developed in that area. There are also different types of analytes, such as mutations that occur in cancer. And so some of the work that's being done is to try to develop more sensitive tests for mutations. There's microRNAs that are preferentially expressed in cancer, and there's some work being done to try to identify microRNAs in cancer as well. But I think there's also, as we have developed the capability also to do really high throughput analysis of the genomes, I think we're getting to the point where people are actually developing assays where you essentially sequence all the DNA that you can find in
That's right.
in the blood sample, and there's this whole field of fragmentomics, as they call it, where you're finding fragments that are associated with cancer and trying to develop assays for them. So that's early detection, I would say. And I think the other factor, a couple of other factors that I'll mention. One is the whole idea that sometimes the best assays use combinations of different types of markers. So using a protein marker with a methylation marker, maybe with a different kind of a marker as well, in combination may be the best markers, and because you can maybe detect cells that are abnormal in different ways. And so that, I think, is a trend we're seeing increasingly. And I think the other trend that's important to mention is the whole area of multi-cancer early detection.
Right.
And this points to the idea that we can potentially, within one test, include biomarkers that detect multiple types of cancer. And if we think about cancer control from a public health perspective, hopefully, if we can get some of those tests down to costs that are more affordable, it would be possible for any individual, for example, to have a test every couple of years or every 3 years on a regular basis to try to identify the development of multiple types of cancer at the same time. I think those are some of the trends that are quite promising. I think in terms of detection of cancer, there's also advances that we are seeing in the area of imaging.
Right.
And so there's work that's being done in the area of imaging to try to develop less expensive imaging methods, but then imaging methods that are using some of the newer technologies such as artificial intelligence, machine learning, other technologies like that, to try to increase our ability to detect abnormalities within tissues such as the liver. Now, in terms of treatment, I think that we have, again, we're learning a lot from examining the genomes and the genetics of cancers. And a lot of the work of what we are learning is then leading us to better understand the pathways that are involved in cancer development. And with better understanding of these pathways, then we can hopefully better design targeted treatments against different subtypes of any one of these cancers.
Right.
And of course, one of the major advances has been our improved understanding of the role of the tumor immune microenvironment also in the development and progression of cancers, and the opportunities now to try to attack the what I call the shields in sort of the Star Wars analogy, that you have this spacecraft that throws up shields to protect itself, and the cancer cells do the same thing. They throw up these shields. And if we can use these immune checkpoints, we can hopefully break down these shields and improve the ability to effectively treat these cancers.
Okay, thank you, Professor Robert, so for your very detailed explanation on the treatment, early detection in terms of biomarkers, liquid biopsies, and also the imaging advancement. So I think it's really great to see. So the liquid biopsy are already emerging in our field. So because we can already see the liquid biopsy used in other types of cancer, but it's really great to see cell-free DNA that really happens in HCC now. So we really look forward to the future development on that, and the guidance on the treatment also. So we have we are now very excited about the immunotherapy, but hopefully in the future, we will know more about how we can predict the prognosis of those who receive the immunotherapy, who will respond better and who are not likely to tolerate the drug and may have to change and so on. So thank you, Professor Robert. So maybe we can shift gear a little bit to another thing. So because we know that Professor Roberts, you also devoted to improving the clinical cares among patients in the Africa. So we would like to know more about that also. So as we know, patients in Africa, they have a high incidence of these HBP cancers than, for example, the others like Asian, European, or American. And they also have this cancer at a younger age. So we can see in the like exterior surveillance guidelines, they will advise us to screen it in an earlier age. So we would like to know more why this will happen in Africa, or why the Africans have the highest burdens of HBP cancers, and also what are the major obstacles or the challenge that they are facing now in Africa. Thank you.
Thanks. That's a great question. Yeah, so I think my motivation to try to better understand, particularly liver cancer, hepatobiliary cancers in Africa, really started several years ago as a medical student in Ghana, because on one of my ward rotations, one of our professors admitted a young man to our ward. And I think he really admitted this young man, not because we had a lot to offer to this young man, but so that he could teach us about this important disease. The young man was about maybe 22 or so. He had this large mass in his liver. We could palpate it. And when you put your hand on this mass, you could actually feel the thrill of the blood with each beat of his heart. You could feel the thrill going through the mass in his liver. If you put your stethoscope on it, you could hear the whoosh, whoosh, whoosh with every beat. And our professor said, we know that primary liver cancers are very vascular tumors.
Right.
And so what you're feeling and seeing is really the clinical evidence of this young man, unfortunately, having developed a large vascular tumor in his liver. And unfortunately, at the time, we had really no effective treatment that we could give him. And more recent data would suggest that it's likely that he did not live more than 2 or 3 months after the time of diagnosis.
I see.
And so as I finished my training, moved to the United States because I'm very interested in research to do my PhD, and then ended up completing my clinical training here at Mayo Clinic, I began to have colleagues in Africa who suggested, why don't you come and help us with training of medical students and physicians? And so several of my colleagues and I started a program where we would go and help with training. And in those conversations, as we would discuss different cases, it repeatedly kept coming up that, in particular, the people that they were seeing with liver cancer often were very young. And, they'd be often in their 20s, in their 30s, in their 40s. And so we began, several of us who were in the field of gastroenterology and hepatology, to begin to have discussions about whether there were things we could do to really reduce this burden, because clearly most people had no idea that they had risk factors. They would present with these large tumors and then they would be dead in a short time. But it became clear that in order to really make an impact, we first of all had to show that this was a problem. Sure. And so initially, several of us formed a network, and at our different centers in about 7 different countries across Africa, we collected information on the patients we were seeing, their age at diagnosis, and if we knew what the underlying etiology of the liver cancer was. And it became quite clear to us that one of the major factors that was leading to the early age of onset was chronic hepatitis B infection. And we were seeing that particularly in individuals with chronic hepatitis B in many countries had a median age at the time of diagnosis of around 40 years of age. And so we published this work, and then subsequent to that, we began to ask the question, well, in addition, we see that many of these patients don't know that they are at risk. Even now that, we have means of reducing the risk by treating people with chronic viral hepatitis, many people don't know they have chronic viral hepatitis. So we decided that we would, first of all, establish that if you were diagnosed at a late stage, your survival, as we were seeing, was really short. And we established in a study of about 1,200 people from sub-Saharan Africa, we showed that the median survival after diagnosis was only about 2.5 months. And we found also that only about 3% of the individuals had any idea that they had a risk factor and so were under surveillance, so that someone was checking their liver regularly or checking their blood regularly to see if they were developing cancer. So clearly there's a big need to identify individuals who have chronic viral hepatitis, to determine if they meet criteria for treatment and put those individuals on treatment, and then also at the same time enroll them in surveillance programs so that hopefully their disease can be detected at an earlier stage. And of course, along with that, it's important that we build the clinical infrastructure, that we train surgeons, that we train internists, so that we have better ways of treating the early cancers when we identify them as well.
Right. Thank you very much, Professor Robert. So it's really important problems, and we have to know the problem first, and then we have to figure out the huge burden and let the others or let the world know about that, and then we can do more on that to reduce the disease burden. At least more patients will know about their risk factors before the diagnosis, or they can have the diagnosis earlier, or even by surveillance, so that more can be treated early at an earlier stage. So can we have one more question about the consortiums that you found? So the Africa Hepatopancreatobiliary Cancer Consortium, or the HPBCC. So can you tell us more about the motivations or the visions behind these consortium?
Yeah, so these consortia really have grown out of, these networks that we formed, because as we formed the networks, we began to think, well, how can we most effectively work together across the African continent to address these cancers? And beyond, primary liver cancer, I think many of us in the group working as hepatologists and gastroenterologists were aware also that there was a significant burden of biliary tract cancer and pancreas cancer. And it's often the same people, either on the medical side or oncology side, radiation therapy or surgery, that are treating people with these types of cancers.
Right.
So we decided that rather than separate them, that we would form one consortium to try to work together to try to address the burden of illness and death from all of those cancers. So we've officially formed the consortium, I would say probably about 3 to 4 years ago. And we then applied to the National Cancer Institute here in the United States for funding to help support meetings of the consortium. And we were fortunate to get, the National Cancer Institute provides seed funding, give you a little bit of money, and then you have to go to do these meetings. But it was important seed funding to help us to develop the consortium and have the initial meetings. And so we held the first meeting of the consortium in Cairo in Egypt in August of 2022. Held the second meeting in Accra in Ghana in West Africa in August of 2023. And we're just beginning to plan the third meeting of the consortium which will be held in Mombasa, Kenya in August of 2024. And so we're really hoping that, members of the community, of the medical community, members of the scientific community, that industry partners, and other foundations might consider aligning with us and collaborating with us to help develop this consortium and make a difference in in cancer care in Africa.
That's great. Thank you, Professor Robert. So really congratulations to HPBCC for the two very successful conference in Egypt and also in Ghana in the past 2 years. And we really look forward to the next one in Kenya this year. So maybe for our last question, we would like to know more about the conference itself. So what would be the objectives and also the target audience of this conference? And as a co-founder, so what are your aspirations for these upcoming meetings in Kenya or the future conference by AHP-BCC, and what will your ambitions or you on the trajectory or the potential of the conference or on AHP-BCC in the future?
Thanks. That's a great question. I think broadly, our vision is that we will be able to identify key factors and key initiatives that can catalyze the reduction of the burden of these cancers in Africa, the liver, pancreas, and biliary tract cancers. And we hope to first of all start at the end of prevention. So things that we can do in working with different countries, different governments to prevent the causes of these liver cancer, for example, biliary tract cancer, we think are key. And so for each conference, we actually start there with the epidemiology and prevention. And then we want to do things and understand these cancers in Africa and be able to develop techniques and methods for early detection so that we can detect the cancers at an earlier stage. If we can detect the cancers at an earlier stage, hopefully then we can, improve the treatment opportunities, improve training of physicians, nurses, other healthcare personnel so that we have the resources to be able to improve treatments. Now, part of it, we recognize that not everyone will be diagnosed with early stage disease. So part of it has to be understanding advanced cancer in Africa so that we can hopefully determine if there are particular types of treatments that should be developed to improve cancer care in Africa. A particular need, of course, is that many of the countries in Africa have relatively lower incomes. So the per capita incomes in many countries are lower. And many cancer treatments that are developed in Western countries or industrial countries are quite expensive. So one of our particular interests is in working together to see if it's possible to develop treatments that can be designed so that they're cost effective within more low resource settings. And so that's I think a big interest of ours. And then I think the other aspect, of course, is if for patients who present at the end stages of life, is important that we have developed palliative care programs so that they can be treated and they can have a death with dignity. Beyond that, we recognize that this isn't something that can be done just by the medical community. So we feel like it's really important to increase awareness, to include patients, to include community organizations, and to engage with communities and organizations in countries broadly. So we hope that these are meetings that will not only be attended by the medical community, but actually broadly by community organizations as well.
I see. Thank you, Professor Roberts. I also really agree with you about the importance of primary prevention. We have to understand the epidemiology first so that we can prevent the cancer burdens in the future, or at least we can preserve the liver function of most of the patients so that more of them, when they really have cancer, they are more suitable for more treatment options. And of course, about the advance in treatments and the cost, how we can reduce the cost so that more patients can receive the treatment and also the holistic cares to the patients, the whole experience for the patients. So I think this is all questions that I have for you today, and we hope that we can have a future collaboration between us and also between the hepatoma research and the AHP-BCCs. And I can see that we have a lot of synergies in between, so that we have similar focus on cancers and also similar understanding on the importance of primary prevention and also advanced treatments and also different etiology, different risk factors for developing cancer, so that we can hopefully reduce the burdens of cancer in Africa and also in other parts of the world. So once again, I would like to thank you for the time for the interview for Professor Roberts, and hope you have a good evening. And I think I will pass the time back to Ada. Thank you.
Thanks very much.